thanks everybody for coming to my talk. And of course, it's nice for me. I'm a PhD student that I'm invited to present parts of my PhD here on this conference. So basically, what we are working on is some prognostic marker analysis in a retrospective study of colorectal cancer patients. And what we found is actually already mentioned in the title, but I would like to give you some more details in the introduction first, because we haven't heard so much about colorectal cancer and cancer in general. So actually, why we're interested in the prognostic marker for colorectal cancer, because in the end it's the third most common cancer for male and female worldwide, the second even leading cause of cancer after breast cancer. So we have a high incidence and mortality rate in the world. So that's why we're really looking for something to predict or have a prognostic marker for for high-risk patients. So basically, the old model, the traditional adenoma-carcinoma sequence in colorectal cancer, is based on the accumulation of several mutations in different pathways. For example, the APC beta-catenin pathway was always supposed to be the initial mutation that it forms to adenoma and the basis for all colorectal cancer. And for example, KRAS or BRAF mutation, we heard already something about KRAS and BRAF yesterday, and also about the PI3K pathway and the tumor suppressor gene P53. These genetic alterations lead to further steps in the carcinoma and also to the late carcinoma, and in the end it comes to the metastasis formation. Basically, during the last decades, this traditional model of an adenoma-carcinoma sequence is improved, and the recent model includes several pathways. They are able to form colorectal cancer. The traditional pathway reflects here. That's actually characterized always by an APC mutation, leads to small adenoma, and further mutations in other pathways, what I already mentioned, leads to higher grading of the adenoma and carcinoma. So this cancer is characterized by microsatellite stable tumors, chromosomal unstable tumors, negative CpG island methylator phenotype. So they are not often methylated promoters, could be identified of several genes, and by KRAS and BRAF wild type. The other pathway is, in the meantime, included, is actually really interesting, is a C-rated pathway based on the structure of the crypts, and it's, in the meantime, also an FDA-approved pathway and a way of distributing different colorectal carcinoma. And what you can see here is that the basis for this is actually the BRAF mutation and not longer only the APC mutation as the reason for initiation of the cancer. And in the end, it comes always to the usual things like TGF-beta. We already heard that it's really relevant in cancer and leads to transformation, malignant transformation. And also microsatellite instability and KRAS mutation as well can happen in this phenotype. On the other hand, we have also a pathway is called alternate pathway, where we have also KRAS mutation as an initiator, and it's characterized by microsatellite stable phenotype and also CpG island methylator phenotype quite low, and the KRAS mutation. So this is actually for later on that you can understand what I'm doing and what I'm interested in. So basically, what also reflects the importance of identifying prognostic markers is that the different stages of the carcinoma are actually associated with certain survival, and you can see significant differences between stage 1, stage 2, stage 3, and stage 4, where the patients already developed metastasis. And this metastasis is actually the most problematic burden and limitation of the patient cure and the survival, because the 5-year survival has actually dropped down to less than 10% of these patients. So we need really a prognostic marker to identify patients at high risk, not only for for colorectal cancer in general. More important in our studies is even the metachronous metastasis formation. And what we found, and our group actually characterized, it's called metastasis associated in colon cancer 1. It was identified in 2009 by our group. It's a new gene. It was never described before. And it was identified by using several portions of adenoma, of carcinoma, late carcinoma, metastasis, and compared to normal mucosa. And what we actually found in the initial study, also in patients, was that in primary tumors, at the time, the tumor was not metastasized, but later on developed metachronous metastasis. The MAXI expression was significantly higher compared to patients never developed any metastasis. So it was for us the indication that this gene might associate it with later metachronous metastasis formation. And even already in early stages, you can distribute the patients in low and high risk patients. And this is actually reflected here in this graph, that patients with low MAXI expression have a lower risk to develop metachronous metastasis, and patients with high MAXI expression have a high risk to develop metachronous metastasis during the follow-up period and later on. So it was shown in colorectal cancer, and it identified in colorectal cancer. But the interesting part actually is that in the meantime, since 2009, it's shown in a variety of cancers, of mostly solid cancers and not so many non-solid cancers, and really associated with the gastrointestinal tract. You have a lot of different studies based on that this gene is prognostic for reduced metastasis-free survival, for progression-free survival, and as well for overall survival even. But for us, it's still the most interesting part always to look for metastasis. And it's also in breast cancer or ovarian cancer, so it's a huge variety, and also some studies in glioblastoma. So it's a kind of really interesting prognostic marker. And therefore, we wanted to look how we can fit this marker into the general landscape of prognostic markers are available in the colorectal cancer. Basically, there are several studies based on APC mutation, P53 mutation, KRAS mutations, BRAF mutation, MSI status, and these things are all like not so same distributed. There are several outcomes based on these studies, and the only promising one was actually always MSI status. So we included several markers. We included the MSI status in our study, and the different mutations in the codon 12 and the codon 13 of the KRAS, and the BRAF V600 mutation, what's basically the most common in colorectal cancer and in general BRAF mutation. And first of all, we looked for correlations between MAXI expression and these different mutations and characteristic or alterations of the genetic background. And what we found again, that we see an significantly increased MAXI expression in primary tumors later on develop metachronous metastasis. Comparing wild type and KRAS G12 or G13 mutated tumors, so wild type versus mutated, also gives a significant value. But interestingly, distributing G12 and making separate analysis with the G13 showed up that actually the G13 is the driver for this significant correlation, and not the G12 mutation, because you can see here the p-values are, this is significant and that's not. So what we also found that the MAXI expression is increased in BRAF wild-type tumors and also in microsatellite stable tumors compared to microsatellite unstable tumors. So of course we are not only interested in association, we are talking about prognosis. So we would like to see how is the survival analysis and what is the relevance for that. So that's why we checked for the association of the MAXI expression with these different mutations concerning the metastasis-free survival, because that's what I say. We are more interested in metastasis instead of overall or overall survival. So what we did already in 2012 in cooperation with another group, we checked in 179 patients with UACC stage 2 colorectal tumors if we could reproduce the same results we found in the initial paper, and that's what you see here, is that MAXI was under several different markers were checked. The only really prognostic marker came up for metastasis-free survival prediction. And what you see here was actually that KRAS has a trend, but it's not significant for reduced metastasis-free survival. But in this cohort, we only analyzed wild type versus mutated, so we didn't do a separate analysis. And during the last years, it came more and more interested to look at different mutations and not only on mutated or non-mutated. So therefore, we included this time in a cohort of 99 patients the MAXI expression, of course, again, and we can reproduce the things we showed before. So it's again prognostic for metastasis-free survival. Comparison between wild type and only mutated without separating G12 or G13 doesn't show a significant value, p-value. And again, it's the G12 mutation actually drops down or increases the p-value. That's why it's not significant. And when you look at the distribution for the KRAS G13 mutation, it's actually prognostic and significant prognostic for metastasis-free survival. So these patients harboring a KRAS G13 mutation had a reduced metastasis-free survival. We also checked, of course, that's what I mentioned, the promising markers like BRAF and MSI status, and in case of BRAF, you don't see really a trend, and in the MSI status, you have the trend. What it's reported in the literature is actually a really consistent marker, but not in the context of metastasis. That's why we were not so surprised that this is only in trend and not prognostic. So what we also checked, of course, was how is this prognosis influenced by different parameters like age, gender, the UACC stages, the grading, and the post-operative treatment. Especially the post-operative treatment can have a huge impact on the outcome of the patients, for sure. And that's why we included all this parameter. And what you can see is that MAXI expression was highly significant for prognosis, and the patients with higher MAXI expression had 6 times increased risk to develop metachronous metastasis, and it's an independent prognostic marker. And we compared also again mutated KRAS versus wild type, and there was no significant at all, and also the G12, so it reflects the same pattern we had before. And the KRAS G13 mutation, you can see here that it's also significant and independent of the parameters I mentioned before, and that these patients have a 5 times increased risk to develop metachronous metastasis compared to wild-type patients. And what we then thought is, okay, let us combine the 2 independent markers for prognosis and see what happens with these patients. And what we found was actually comparing high MAXI expressors distributed by the KRAS wild-type and versus G13 mutation, that there's a significant reduction of the metastasis-free survival of these patients. And these patients had a 14 times increased risk to develop metachronous metastasis, and it shortens the metastasis-free survival dramatically. So this indication was already really nice, that it's it's a possibility to identify high-risk patients in combining these 2 prognostic markers. And we went ahead because I mentioned the former different pathways we have, and did some cluster classification based on cluster function, and included all the genetic alteration we have seen before and was also mentioned in the recent model. And what you can see is basically that based on this cluster analysis and on the different parameters included here, the KRAS G13, MAXI expression, BRAF, and MSI status, that we got 4 different clusters, 4 different groups. And then I did a Kaplan-Meier analysis, and what I found was actually that these patients have all different risk for metachronous metastasis development. So what these clusters are, what you can see here is actually that in the first cluster we have a KRAS wild type, a low MAXI expression, mutated BRAF, MSI high, and in the second cluster it's the opposite, or it's a different thing. It's a wild type. We have low MAXI still, but we have an MSS. And when you compare 2 and 3, you actually see that the only difference is based on the MAXI expression. You have here low MAXI and you have here high MAXI. And this is reflected also in the risk for developing metachronous metastasis, that you can see that these two are based on the MEXI expression can be further distributed. And the fourth cluster was characterized by KRAS G13 mutation, high MEXI expression, a BRAF wild type, and MSI MSS, and had the highest risk for developing metachronous metastasis. And these patterns actually reflect the former several pathways. So we have here one cis-related pathways characterized by BRAF mutation and MSI high and low MEXI expression. So these patients have a low risk for metastasis formation. Then these two different groups, that's what I mentioned, they only differ in the MEXI expression. One have low, one have high. So it allows us to distribute this traditional pathway group based on the MEXI expression in a low risk group and in a high risk group. So, and the last fourth cluster with the lowest or with the highest risk for metachronous metastasis are basically characterized by KRAS G13 mutation, BRAF wild type, a microsatellite stable phenotype, and high MEXI expression. So it reflects the former presented Kaplan-Meier analysis that these patients are actually characterized by KRAS G13 and MEXI, but we also included the BRAF and the MSS status, and this reflects all the data shown before. So I would like to give you a summary of the data, what I showed you, that the MEXI expression or high MEXI expression in combination with the KRAS G13 mutation or both of them are independent prognostic markers for metachronous metastasis development. And patients are characterized by high MEXI expression and KRAS G13 mutation exhibited the worst prognosis. So these patients are actually the high-risk patients for metachronous metastasis. And further, what we showed was that when you include MEXI and only the KRAS G13 mutation as independent markers in our conventional CRC classification, we are able to refine this classification further by putting these markers in addition, or especially MEXI in addition. And to sum up this thing, it allows kind of an improved individualized therapy if you can or identify patients with high risk based on their genetic characteristics for further intervention strategies, and to have that maybe also in the clinical routine because KRAS is already a common checked marker in the clinics. So it would give possibilities also for intervention strategies. So I would like to thank, of course, all my co-authors and co-workers based on this work and our financial support. And I would like to thank you for your attention and for staying here. It's still tough for us to say where it's really in. So basically what we have is, until now, that MEXI is involved in the c-Met HGF signaling. So it drives metastasis, also cell migration and invasion via transcriptional activation of MET itself, the receptor tyrosine kinases. And the HGF treatment basically leads to translocation of MEXI from the cytoplasm to the nucleus. So it's a positive feedback loop, and there are some further indications that, for example, the MAP kinase pathway is somehow associated. That's why we came also to that story if there's something associated. And in the meantime, there are further investigations. There's also the PI3K and AKT, so it's a general oncogenic pathways are also somehow regulating MEXI. But to be honest, there are not so many basic research paper available on that. So we are working on it, and we try to identify how the real mechanism is. Is it phosphorylated? Is there some possibility how it's shuffled, and whatever reason it comes also, or what is the reason for the upregulation in the normal or in the primary tumor already, and in the metastasis especially, how this is regulated. But so far we are not so many information. No, it's the G13D is the most common, but I didn't distribute it further because the G12, there are different ones. We looked also the separate G12V, G12C, G12D, but it's just the number of patients. You have more and more subpopulations getting more diverse, and you cannot make so much analysis with such a low number of patients. So actually, we were always limited in our material, what we get. We had only mRNA. We didn't have an antibody during the time when we did the study. In the meantime, we have a good working immunohistochemistry antibody, so we tried to expand this analysis further, and then we would also distribute the different mutations. That's definitely an interesting point.
So your most study is G13D?
Yeah.
Further questions? I have one question, Katharina. Interesting talk. What's interesting to me is what fraction of the patients who actually go on to have metastases, in other words, the large group of patients who may be at risk for metastasis, what fraction of those have the combination of the MAXC1 and the G13 mutation in RAS? In other words, if you're predicting these patients are at high risk for metastasis, do they account for a very large proportion of those people at risk for metastasis, or only a small subgroup? Do you have a sense of how many patients you are
Addressing
finding the risk in?
So actually, it's when the people come to the clinician, the most of them are already in later stages. So actually, you address a huge number of patients that they're already in the later stages of the disease, and also develop later on metachronous metastasis. So in our study, it's like 1/4 of all of them, so 25%.
Oh, I see. That's interesting. So about a quarter of the patients who have metastases are those that have the combination of the MAXC1 and the
No, of course, we have only this 5% we show here, because that's what I mean. We need to, because the KRAS G13 is rare. It's more rare than the G12. That was our problem. It's a low number. Yeah, that's really true. That's we're facing always, because actually we, based on the literature is available, we expected to see more interesting combination with the G12 mutation, because that's really shown already in several papers that might be a promising prognostic marker. So we were kind of surprised that the KRAS G13 turned out to be relevant for that. That's why we want to investigate further to see how this combination really works, and how many patients in a bigger cohort are having this combination for that.
No further questions? Thank you very much, Katharina. Very interesting.
Thank you.